Well, welcome. If you are here today at 11 o'clock to join me with Melanie Chadwick to hear about updates in Alzheimer's treatments and medications, you are in the right place. I am Kirsten Parsons with Ingleside. I do want to introduce you to our communities. We're going to wait for just a minute as everybody is logging in, and then I look forward to introducing you to the 3 Ingleside communities, my role with Ingleside, and then I will introduce Mel, will be sharing with us quite a bit of information today. Certainly, I think an hour is a safe bet for how long we'll be together for her presentation, and then we'll have some question time after that. All right. Well, I just want to introduce myself, Kirsten Parsons with Ingleside. I do have the privilege of working at all 3 of our communities. So if you're not familiar that we had 3 communities, or if you're only familiar with one location or not at all with us, I can share with you Ingleside at Rock Creek is our flagship community. So the oldest of our 3 communities dating back to the early 1900s. We've been on the property at Military Road since the 60s. All 3 of our communities are life plan communities. So independent, assisted, and skilled services all on one campus. We also do quite a bit in memory programming and services at all 3 of our communities. And it differs a little bit at each one, whether we have a social day program or a residential program, but I'll share that with you. Westminster at Lake Ridge is our sister community in Prince William County, Virginia. Also a life plan community. It is our only community that has cottages on the property. And then Ingleside at King Farm, the baby sister of the 3 communities, was opened in 2009 in Rockville, Maryland, in the King Farm neighborhood. I think it's helpful to share what's currently available at the communities. At Ingleside at Rock Creek, we do have 1 available floor plan in our memory support assisted living program. So again, this is similar to a memory program like a social day program, but it's actually a residential setting and combined that active programming with the assisted living level of care. This is at Ingleside at Rock Creek in Northwest DC. At Westminster at Lake Ridge in Prince William County, Virginia, we do have 1 floor plan available in our traditional assisted living. And at Ingleside at King Farm, I have a floor plan in our memory support assisted living and in our traditional assisted living. So I want to share something with you that can be a great opportunity if you're on today's call listening for a friend, or maybe it's your loved one that has a dementia diagnosis, and there are times where you felt like you need a respite for yourself as that primary caregiver. I do want to share that Ingleside, as we have availability, has the opportunity to do a respite program. And so that's for 30 days. Your loved one can, in essence, trial being in our residential memory programs. And that gives you, the primary caregiver, that respite from being on 24/7 as their driver and entertainer and care manager and nurse. And so this is a great program to talk to your medical team about and say, hey, is this something that would be appropriate for my loved one? Or if you're on today's call for a friend, mentioning this to them, that Ingleside can offer this. I do want to make you aware of an upcoming educational event. We partner with the Sibley Senior Association to make sure that we're getting good information out to the community, and their conference Journey to Hope is next Saturday. So not this week, but the following week on May 13th. This is a free seminar, and it's kind of all afternoon. So noon to 5. Again, it's free, and you can, there's an email here at the bottom to register. If you don't grab that right now and you want to register, just send me an email or call me after this webinar today, and I can share with you how to register for this Journey to Hope conference in partnership with Johns Hopkins and Sibley Senior Association. All right, so again, that's my phone number. If you want to jot down that, it's a cell phone. You can text or call me, and any follow-up from today, whether that's learning more about Melanie and her team, if that is learning more about Ingleside and where we have current availabilities, or if you want to come over for lunch and a tour, or if you want to register for that Sibley Senior Association event and you just didn't catch the information, please text or call me and I'd be happy to answer those questions for you. So without delaying any further or cutting into Melanie's time, I want to introduce Melanie Chadwick. She is with the Georgetown University Memory Disorders Clinic, and we are so privileged to have her sharing with us today. I'm going to stop my screen, Melanie, so that you can share yours. And I just want to ask that our participants type questions in the chat or the Q&A feature. We're going to get to those at the end. Melanie has a lot of information for us. And so you can type those in at any time throughout. That's not a disturbance at all, but we're not going to address those questions until after that hour mark. And then we'll spend some time together going through your questions. Melanie will likely answer some of those questions even as we progress through the webinar together.
Hi, well, thank you so much. I'm actually very excited to be here. I'm a little so excited. I got a text this morning from Lilly Pharmaceuticals stating that one of their drugs showed some very positive preliminary data. So just within 5 hours, we have some new information, and I was able to actually slip in one slide and hopefully talk about it a little bit. So the audience here will have more about this new novel drug than probably anybody else in the community right now. So that's going to be great. What you're seeing in front of you is my team, my colleagues. Our memory disorders program is a little bit unique in that 75% of the program is devoted to our research trials. We are employees of the university. Dr. Raymond Scott Turner is our primary investigator of all of our trials. We also have 4 nurse practitioners, including myself. I am a gerontological nurse practitioner as well as a certified dementia care specialist, and we act as sub-investigators for our trials. We have about 10 trials going on right now at Georgetown, specifically devoted to Alzheimer's disease. And then, of course, our team rounds out with our wonderful study coordinators who we couldn't do this without, for sure. So I want to try to get to the next slide. So the objectives today really are to get a grasp of overall what dementia and Alzheimer's disease specifically is, learn a little bit about Alzheimer's research, the past, the present, and the future, what's failed and what's looking like a success, how clinical trials work. And this is important if you watching this or a loved one with Alzheimer's disease may be interested in a clinical trial, how to go about doing that, and then ways to participate in a trial as well. So the first slide really, and the question I get a lot is, well, my loved one has dementia. And I'll say, well, what form of dementia? And they're confused by my question and don't understand that there's a difference. They think the word dementia is their diagnosis. And then they'll tell me, well, they haven't been diagnosed with Alzheimer's disease, they just have dementia. And so it can be very confusing to the layperson. So I like to start off my slides with kind of differentiating the two. So dementia in itself is a symptom. It's not a diagnosis. It's a clinical syndrome, which consists of a variety of symptoms that really are characterized by the decline of our intellectual function, and it significantly there impacts our functional capacity and our social abilities. So dementia is a symptom. Something's causing the dementia, similar to a cough. A cough is a symptom. Cough is not a diagnosis. Something's causing the cough. That could be COVID, that could be asthma, that could be the common cold. So we have to dig deeper to figure out why someone's coughing and again, why someone has this dementia. And one of the leading causes of dementia, which is about 65%, it actually could be higher now, is due to Alzheimer's disease. There are other forms of dementia, such as vascular dementia, Lewy body dementia, frontotemporal dementia. I'm not going to go into those in particular because the focus is Alzheimer's disease, and that's the research that we're really geared to investigate. So again, Alzheimer's disease is a neurodegenerative process. It is progressive. There is no cure at this time, and it's most common over the age of 65, although we do have people between the ages of 40 and 64 who have the disease. Which is rare in about 5% of that 6 million people who have Alzheimer's disease. And it is defined by these abnormally clumped and tangled proteins in the brain. And that over time, many years, 10 to 15 years, damage healthy neurons, causing them to stop functioning. So I touch a little bit on Dr. Alzheimer, German doctor. Again, he did some wonderful work, but he gets all the credit. And I've read a lot of literature and books, and there were many other German doctors, including American scientists as well, that contributed to his science, but they just don't get the namesake that he did, but they should be recognized. But in 1906, under the microscope, not an electron microscope, but what he had, he was able to see these changes in the brain. In fact, a young woman, she was in her 40s at the time, And that would be considered early onset Alzheimer's disease now in the 21st century. But she was suffering from a mental illness, and they did not know what that mental illness was. So he was able, on autopsy after she passed away, look at brain tissue. And he found, comparatively to other brains that on people who did not have this disease or mental illness, he saw these clumps that we now call amyloid plaques. And he also saw tangled bundles inside the neurons that he called, tangles, but now we call them neurofibrillary tangles. And so that's really what he discovered at that point. And it's now what we consider the hallmarks or the signs pathologically of Alzheimer's disease. So to kind of put it in a prettier picture, when we think of plaques, I think of the sludge that's on the side of an artery in the neck or in the heart that can cause, vascular damage. But plaques in the brain are a little bit different. They're not in the arteries or the veins. They're actually in the brain tissue themselves. And if you look at that little red, what looks like a flower to me, that's considered the plaque. And that's an abnormal clump of a protein called amyloid. And it starts to develop and become clumped possibly 10 or 15 years before someone even has symptoms that are prevalent that cause someone to seek medical care. To the left of that, which kind of looks like a teardrop, is the tangle, and that's actually a neuron. And it is now a dying neuron because these tangles were able to get inside of that and destroy that. So if you were to kind of look at a cartoon picture, that's what it would look like in the brain. And then over on the right-hand side, we do special PET scans called glucose PET scans. And this looks at the function of the brain and how well the brain can take up glucose metabolism. Our brains are very reliant on glucose to operate. So for instance, if you hadn't eaten all day and you're really hungry, you don't think very clearly. You're foggy in the head. You've got that foggy brain because our brains are saying to ourselves, hey, we need the sugar. We don't have the sugar. Our brain's not working properly. And so we can look at these PET scans, and with someone with Alzheimer's disease, these proteins cause cell death. And when cells die, they can't bring in that sugar and operate like they should. And so PET scans will look different in color. And we can see that in PET scans. So that's one of the ways we help diagnose Alzheimer's disease. And it has a pretty good specificity and sensitivity to that particular imaging. So symptoms of Alzheimer's disease, I'll quickly run through. The top left-hand corner, of course, this is a brain on autopsy. On the left-hand side of the brain, that's a healthy brain. Someone who has advanced Alzheimer's disease, it is more shrunken. Of course, when brain cells die over time, over years, the brain tissue itself will shrink in size. So that's what we would see on autopsy. So the beginning symptoms of Alzheimer's disease classically starts with the inability to hold on to new information. We also know that there is a department in our brain called the hippocampus. And I'm not sure if can you see my arrow here? Do you know? Can anyone see my arrow? No?
Yes,
so
we can see it, Melanie.
You can, okay. So here in this part of the brain is what the hippocampus is. And the hippocampus is where we take in new memories. So when we learn a person's name or when we learn somebody's address, this is where that information is stored. And it typically, not with all patients, but typically Alzheimer's disease starts in that area. If you look at the right-hand side here, this is where the hippocampus is now with advanced disease, and it's much smaller and pretty much non-active there. So people with the beginning signs will have this decline in their cognition. They may repeat stories, not realizing that they've already told the story maybe a couple of hours earlier. Or if they've had a conversation with their daughter on the phone the day before, and then the daughter revisits that conversation the next day, that person may act like they've never heard that conversation. You didn't tell me that. And of course, the other person on the other line is, yes, Mom, we talked about it yesterday. Now that can happen, with people who don't have dementia. But what the symptoms of Alzheimer's in the early stages really come down to is consecutiveness, and not something that's happening here and there a couple of times a year or maybe once a month. This is something that's happening on a consistent basis. They lose track of date and time. It's hard to really get coordinated when it comes to getting ready for a doctor's appointment, for example. So if someone lives an hour away from their doctor, they know what time they have to get up, how much time to prepare, and then what time it's going to take to get there. And so that planning could be very confusing for someone in the very early stages. And then they also have a reduced ability to solve common problems. Try to figure a common problem. This could be just maybe a wrong bill on a phone bill. So I have this problem. I need to call the phone company. If I do A, B, and C, I can get this rectified. Sometimes there's the ability to handle that problem is difficult because they don't know how to sequence the steps of how to solve that problem. And again, trouble making choices, poor judgment. This isn't simple choices such as what am I going to eat for dinner? This is more complicated choices. Getting disoriented in familiar places. So again, this isn't going to a new place or a new destination and using your GPS. We all get turned around in new places, but this is familiar places. This could be in your neighborhood or right outside your neighborhood, common routes that you take. We see people get disoriented, either walking or driving in those familiar places. And sometimes the inability to follow directions, that can also be a sign of Alzheimer's disease. So diagnosing Alzheimer's disease, can be difficult at times, but it has been much better over the last, I would say, 10 or 15 years. There's really right now, not one single diagnostic test that can determine whether or not you have Alzheimer's disease. What I always tell my patients or potential patients or their families is, if you're concerned, please always start with your primary care. Your primary care doctor is your gatekeeper. They know you more than I do. They can start that groundwork, because a lot of symptoms for Alzheimer's disease can be reversible, or maybe it's from an outside factor, like a new medication you just started, or maybe a vitamin deficiency you have, or an impairment in your blood sugar or your thyroid. So that's where the primary care really does take the reins and say, okay, let's rule out all these other possibilities before we just, hone in and say this is Alzheimer's disease. So it really does start with your primary care doctor. And if that primary care doctor, does that front work and really feels like we need to take the next step, I've done all these tests and I'm not really seeing anything outside that's reversible, then maybe it's time to refer to a neurologist. And so a neurologist then will go a little bit more thorough. They'll do more of a formal neuropsychological evaluation, which really tells us our strengths and our weaknesses in many different cognitive domains, because it's not just short-term memory. There may be other cognitive domains that may be affected, such as your language or your executive function, for example. And again, we want to look at labs. We want to go over those medications. Are there any medications, any antihistamines, any opioids, anything that could be fogging the memory of the brain that could explain what's going on? And then, of course, lastly, there's brain imaging that starts usually off with an MRI, which involves a magnet. So there is no radiation, there's no contrast. It can be done with contrast, but we typically do it without contrast just for safety reasons. But what that does is it tells us the structures of the brain. It cannot diagnose Alzheimer's disease, and I'm very specific about that. When I call a person and say your MRI was normal, that doesn't mean that you don't have Alzheimer's disease or a dementing process. What it means is structurally, I could not find anything in that MRI to tell me that you've had a stroke, to tell me that you have a tumor, to tell me that you have some swelling in the brain, like hydrocephalus, to explain your symptoms. And then other brain imaging could be the PET scan, as I mentioned earlier in the slide, that glucose PET scan as well. So those are some of the diagnostics that we use in assisting with Alzheimer's disease diagnosis. So this slide talks about the current treatment. And these are the current FDA drugs for Alzheimer's disease. And if you look, of course, at number one and go back to, or go over to the right, when it was FDA approved, that was 1996. And then we look over at number three, which is memantine, and that was approved in 2003. And honestly, since 2003 up to 2021, we haven't had any new Alzheimer's drugs in that time frame. And it's pretty devastating and eye-opening to me, but hopefully in the next couple of slides, I'll explain why. So what we have on the market now, number 1, number 2, and number 3 are all in the same class of drug. They are all cholinesterase inhibitors. Number 3, which was FDA approved in 2003, is a different medication which targets a different protein. So all of these medications are actually to help with symptoms of Alzheimer's disease. These in no way are disease modifying medications. They don't target specifically these plaques and these tangles. They just assist with the symptoms. So what they do, number 1, number 2, and number 3, is they enhance a neurotransmitter in our brain. This neurotransmitter is very depleted with Alzheimer's disease, and it's just not turned on in the brain. And these neurotransmitters are responsible for helping messages get from one neuron to the next. So I treat neurons like the train stops, the train station, stops. And then we've got our dendrons and our axons and dendrites, which kind of act as the railroad tracks. And these messengers are like the gas to move the trains from one station to the next. And when you don't have the gas or you don't have these transmitters, messages can't get from one place to the next. So what these medications are really meant to do is enhance and kind of wake up those neurotransmitters to say, hey, do your job. And so that's what these medications are meant to do. Number 3, memantine, approved in 2003, was really approved for the more moderate to advanced stages of Alzheimer's disease. There is a chemical in the brain called glutamate, which tends to be good, but in the advanced stages of Alzheimer's disease, the disease turns it toxic and it becomes bad and not good anymore. And so what memantine does is actually blocks that toxicity. So that chemical glutamate can't, or I say can't, but it still can do harm to the brain. So that's really how memantine is different from the other 3. And then there was one pharmaceutical company who got real sly and smart and said, hey, why don't we put number 1 and number 3 together into one tablet, market it as a new medication, and then charge people more for it. So I remember this commercial coming out in 2014, and they were, stating new drug for Alzheimer's disease. And I'm sitting there with my hands on my head going, no, this is not a new drug. This is a marketing campaign. It's just 2 drugs put in one pill, the same drugs, and marketed as a new drug. So we really, because it's a high tier drug and insurance companies really don't reimburse for it. I have never prescribed Namzaric number 5. I typically will start off with 1, 2, or 4. And then as the disease progresses, some years down the road, I will then add memantine and then have those 2 different classes of drugs ongoing for most of their time with me. And then, of course, outside of the pharmaceuticals, we have to think about other activities that are just as important as medications. And we have learned, through research and, I see it all the time in the newspaper and news, physical activity, mental activity, staying social, which really was harmed and was devastated during COVID. We really found out through COVID that we are social beings and that our mental health and our memory really are, suffer when we don't have that social activity. And of course, our diet is always important and contributes to our brain health, heart health, and our overall health. So what we do at the Memory Disorders Program is really highly recommend the Mediterranean diet. So these are other mechanisms to stave off cognitive decline, to include the pharmaceuticals as well. So let's get into the nitty-gritty. Alzheimer's research, past, present, and future. So going back to the past, we start in 1906 with Dr. Alzheimer. And this is where he really had his first patient and identified these plaques and tangles. It wasn't really until 1910 that the disease was actually given a name. But when you look between 1910 and the 1960s, there really wasn't much going on. I think people were still considered having a mental illness. Family members would call them demented or senile. There really wasn't that much that scientists or doctors really learned in that time frame. And it really wasn't until the 1960s where we had more advancements with technology. The electron microscope came out. Wow, now we can zoom in and see these plaques and tangles even greater than we did, previously. And moved in to the 1980s, where we had even more molecular and biochemical advances. We now identified these plaques and tangles as amyloid proteins and tau proteins. We actually gave them a name. And then moving into the 1990s, that's when the genetics really had a boom, and we could figure out whether or not something was sporadic and it was just happenstance due to age, or were there really a genetic component, a mutation, I will say, in someone's chromosomes that predisposed them to Alzheimer's disease. All of that was starting to make a big turn in the 1990s and into the 2000s. And then we're getting here to the 2000s. It's really where we have an understanding of the processes that cause dementia. We had a better understanding of genetics, the biology, and the brain imaging. Around the mid 2000s is when we actually came, I say we, like I didn't, researchers developed even better imaging than the glucose PET scan, and that would be an amyloid PET scan. So this is a special PET scan that does involve a radio tracer, a contrast that is very specific to the amyloid plaques. And so when this isotope is injected intravenously, it travels throughout the body and then goes into the brain and actually attaches to these plaques. And then when we then put somebody through a PET scan, we can see the plaques where we haven't been able to see them before. So this was really groundbreaking in the mid 2000s. And it really pushed research forward, because now we can identify the right person. And this is probably why a lot of our trials failed in the 1990s, is we didn't have this technology. So we were bringing in all kinds of people with memory problems, not knowing through pathology, because we didn't have it at our fingertips, whether or not we were treating the right diagnosis. So we might have someone with a dementia due to Lewy body or a dementia due to frontotemporal dementia that might not even benefit, because we aren't honing in on the cause, and that for Alzheimer's disease are these plaques and tangles. So the imaging has come a long way, which really has pushed research, and it's been really wonderful. And then, of course, in 2020, now that we have this technology and we have better knowledge of the genetics, we can target or choose therapies that specifically target these plaques and these tangles. And in future slides here, I will talk about some of those drugs that have passed through different phases of trials and have made it to the front desk of the FDA. So what we have learned about previous, in previous research, what have we learned? Again, the biggest risk factor is age, and that's really all there is to it. We have learned that family history and genetics do play a role, that genetics primarily meaning mutations. So these are mutations on specific chromosomes, 19, chromosome 1, for example. And these mutations are also rare, and I like to really state that. Of the 6 million people that have Alzheimer's disease, there may be only 5% of that 6 million people that have a genetic mutation that is causing their Alzheimer's disease. Now, again, there's also risk factors for Alzheimer's disease, family risk factors. There is a genotype, which I will get into in the next couple of slides, called APOE. This is a genotype that produces more amyloid protein. And so people who have this specific genotype may be more at risk for getting Alzheimer's disease, but it doesn't confirm that they will get Alzheimer's disease. It is unlike a mutation where you're guaranteed to get this disease. The risk factor is just that. It's a risk factor. We've learned through research that not only high cholesterol, high blood pressure, high blood sugar really does negatively impact the brain, just like it negatively impacts the heart. And so these unmanaged diseases absolutely, having gone unmanaged for periods of time, can preempt, I will say, dementia such as Alzheimer's disease. We're learning more about diabetes as well, because again, as I said, our brains need sugar, but that doesn't mean that we need to have a high sugar, high carbohydrate diet. That's not what I'm saying at all. But when someone does have diabetes or unmanaged blood sugar too high, that's not normal, that really does spark an inflammatory response in the brain, and which really fuels the fire for more neuroinflammation and more of this clumping and tangling of these proteins. We also know gender has a lot to do with Alzheimer's disease. So women are twice as likely than men to have Alzheimer's disease. Yay us. And we're still trying to figure out why. Some people say it's because women live longer, and it's not really it. There tends to be a component that has to do with hormones. And we now know that our estrogen and our progesterone, those hormones that unfortunately we lose during that perimenopause stage, are really healthy for our brain, and they are protective for our brain. And so scientists are starting to learn maybe that it's the hormone factor and the lack of that is causing more women than men to have Alzheimer's disease. And of course, head injury. When you think about a delicate brain being jarred back and forth in a hard skull, it makes sense, that that could definitely spark a fire as well. Learning a little bit more about Down syndrome. And I mentioned Down syndrome specifically because I mentioned that risk factor, that APOE genetic factor. And with Down syndrome, they actually have 2 copies of this particular genotype, which then puts them more at risk for getting Alzheimer's disease just because they have 2 copies. And of course, with COVID, we know, social isolation, absolutely. We're social beings, we're social creatures. We want to be with other people, and our brains want us to be with other people too. And then of course, physical inactivity. So these are some risk factors. Some are out of our control, such as our age, our gender, and some of them, are in our control that we can actually manage and stave off cognitive decline. So I mentioned the APOE gene, and I'll try to be really quick here. APOE, of course, is a genotype, and there are 3 alleles associated with that. And when I say allele, I mean copies. So we get a copy from our biological mom and a copy from our biological dad. And there are different variations. There's 1 in 6 variations that you can get, because you'll actually have 2 numbers, one from mom and one from dad. And there are 3 numbers associated with APOE, the number 2, the number 3, and the number 4. So the APOE4 is the strongest known genetic risk factor for Alzheimer's disease, because it's less efficient at clearing out the amyloid protein in the brain. So carrying one of these alleles, it does put you at a 25% higher risk versus someone who doesn't carry this allele. But what I say is, half glass full, the other 75%, won't go on to get Alzheimer's disease. And carrying 2 copies, so carrying a copy from mom and dad, actually puts you at an increase about 50%. But I also like to point out, only 1% of the world have 2 copies. So it is rare to have 2 copies of the APOE4 gene. And again, age still remains the largest risk factor. So you can go to 23andMe, you can go to these websites that will give you your APOE status, and you could find out that you don't have this APOE4 gene, but that doesn't mean that you're in the clear, because again, age and other lifestyle, risk factors play a role. One can still get Alzheimer's disease without having a copy of APOE4. So I'm just letting that. About 50% of the population are a 3-3. So they got a copy 3 from mom and a copy 3 from dad. That's 50% of the population. We are learning through research that the APOE2 that I mentioned, that specific number, is actually protective. And so people who carry the APOE2 factor or copy actually are protected. And we're trying to figure out what protects them and how can we put that in a petri dish and replicate that, because that would be absolutely wonderful. But we've learned through research a lot about the APOE gene. So as I mentioned earlier, between 2002 and 2019, 99% of our clinical trials for the treatment of Alzheimer's disease had failed. And it starts to make researchers wonder, are we going down the wrong path? You know, we keep looking at this hypothesis or this statement of saying it's the amyloid plaques, it's these tau tangles. Are we really just looking in the wrong direction? Should we be looking in a different direction? So it really made a lot of scientists think. And then also what we realized was that a lot of these trials failed because, number one, we didn't have the technology that we have now. So of course we were probably choosing the wrong population for the wrong drug. And knowing now that this turbulence of clumping and tangles tends to occur 10 or 15 years before someone has a symptom. Well, are we treating people too late? So I don't want to compare it to cancer, but if I start to have a cough, I go in and get a chest x-ray and they say, well, you're in stage 4 cancer. We don't have too much to offer you. I'm like, wow, well, I wish I would have known that 4 years ago. There would have been better treatment, but I didn't have a cough then. I didn't have symptoms. I didn't have anything that made me go to the doctor to say, hey, look at this. And so things have really, you know, been pushed forward, and we can identify people in the more earlier stages now. And so I think trials going forward are going to be more successful because of just that. So I think a lot of the trials in the past before 2019 failed just because we didn't have enough information that we have now, unfortunately. So I'm just putting up a whole bunch of news articles from the past. You know, Merck had a drug, it failed. Lilly's had drugs, it's failed. Pfizer's had drugs, it's failed. So, you know, we keep seeing these headlines in the news, and it can be sad. It can be sad because we're spending millions of dollars and we're not successful. And what a researcher doesn't like is to be considered a failure, that's for sure. But I like this. I like this slide here, and this is not meant to talk about molecular biology. This is going to be a simple slide, and this is how I'll explain it, because it will help you understand why our drugs have failed in the past. So if you look here to the left, this amyloid deposition cycle, this cycle here starts to occur in our brains 15 years before we have a symptom. Damage is beginning. This could be happening right now in my brain, and I don't even know what's going on. And so this abnormal accumulation, this abnormal clumping, it starts to spark an inflammatory response. This starts other inflammatory responses. The cycle keeps going on. It produces more amyloid, more tau, more inflammation, and this cycle just keeps going on and on. And when we start to have neurons that die, really here, if you look in the right-hand side where we have dysfunction, this here on the right-hand side is where our FDA drugs, this donepezil, this rivastigmine, the memantine, those drugs I mentioned that were FDA approved back in the 1990s, this is where our drugs work here. So my point is, why do we have drugs that work here when the damage has been done? So really where we need to focus is not the right-hand side, but this left-hand side. And so the drugs that are currently new, that are coming to the market now, are gearing here. And this is why they're really looking so promising, is because we're catching it so much earlier on this left-hand side versus this right-hand side. So that's really all I wanted to explain, is why drugs in the past haven't worked, or why trials have failed in the past, because we're focused on the right-hand side, but now we're really focused on this left-hand side. We need to start much, much earlier. We need to get this cancer before the cough. So a little bit about drug approval process. When researchers start trials, they always really starts in phase 1. It's typically started in petri dishes. It is started with look-alike cells that that aren't human cells, but are in vitro cells, and it moves to humans. And when it moves to humans, it's phase 1. And that's really the infancy of a trial. We're typically testing healthy individuals. So we need to find out if this is a safe drug, a tolerable drug in healthy individuals before we start giving it to people with illnesses. And it's tested in a small group of people. This might be a group of 10, it might be a group of 20. It's not a very large sample size. And again, the primary endpoint of phase 1 is just safety. If we can prove that safety in healthy individuals, we move it to phase 2, which means it's still tested for safety, but our study population is a little bit larger, and we're testing now for side effects. We're testing now to see what doses this medication is safe in. So we're testing maybe a 5 milligram dose, a 10 milligram dose, and a 20 milligram dose. That would be done in phase 2. If it passes those safety endpoints and appears to be efficacious in that small phase 2, it will then move into a phase 3. Phase 3 is good. We know it's been tested in phase 1. We know it's been tested in phase 2. So we know a little bit more about the medication. Now we're testing it in phase 3 on a much larger population, more wider demographics. So it's outside of the United States. This is worldwide: Canada, Japan, Europe, because different people have the disease, and we need to study a lot of different populations. And we now shift our focus from safety in phase 3 to efficacy of the drug. Of course, we're always looking at safety, but in phase 3 trials, our primary endpoint is, does this drug work? That's really what's important. And if that can be accomplished, that's when the pharmaceutical company typically gets the FDA involved. And the FDA would like to see 2 successful trials. They don't want just one trial. They want this to be replicated more than once, possibly even 3 times with success before they would consider it to be FDA promising. And then phase 4 is after it's FDA approved. Now we have to know the long-term effects of these drugs. These trials typically are about 12 months to 18 months to 4 years. So really that's a short time span. If I'm giving this drug to somebody for the next 10 years, 15 years, what are the long-term effects? So that's when phase 4 comes into play, and we really continue to learn more about the drug. So I'm saying this because it's really going to help you understand the very exciting drugs that are very promising that the FDA has approved and what phase they were in. So our first modifying drug for Alzheimer's disease, aducanumab. We have been studying this drug. I came on in 2014, and we were studying the drug even at that time in a clinical trial. It targets this amyloid. I say oligomers of beta amyloid. It sounds complicated, but it is a developmental form of the amyloid. And so the hypothesis is if we can target that and break that cycle, then we can stave off cognitive decline. And so this drug was given in an 18-month trial. They actually studied it in 2 phase 3 trials, Emerge and Engage. So they did what the FDA wanted. They studied it in 2 separate trials. But it was actually halted back in 2020 because an independent data committee came in and deemed it unreliable. They said this is not efficacious. It's not any better than the placebo, which is the lookalike drug. So then this was also by Biogen. So the company Biogen, the pharmaceutical company, they gathered all, and of course the independent data committee only really looked at half of the data. They didn't look at all of the data. So then Biogen came in and said, okay, let's collect all the data. So they collected all of the data from all thousands of the participants. And they said, wait a minute, we're not seeing the same results that this independent data committee found. And so they said, aha, we do have success. However, they could only prove success in one of those 2 trials. They could not prove success in both trials. But nonetheless, they were overly excited, and so they decided to go ahead and submit that data to the FDA. When this was approved in 2021, Actually, before it was approved, I was a little shocked that it was approved, given the fact that only 1 out of 2 trials were positive. That made me wonder. And then there were also significant side effects of this particular drug. And I will go into that in a couple of more slides. And so it was accelerated. So accelerated approval means that it didn't go down the traditional route. It means it will accelerate. However, you still have to do more thorough investigation of the study drug. And this also means, because it's accelerated, that Medicare and insurance companies do not have to reimburse for this medication. They want to reimburse under SAFE protocol. They want to reimburse knowing that the FDA has looked at this traditionally, gone through the traditional route, not this accelerated approval. So Medicare and insurance companies kind of said, hands off, we're not reimbursing this drug. And so that's really what it came down to. And when this drug was studied, it was only studied in early disease. It wasn't studied in the moderate stages. So we only know that this may be effective in mild cognitive impairment and Alzheimer's disease. So again, it's given in an intravenous fashion. And what it does is it clears these plaques from the brain. And our hypothesis is, if we can clear the plaques, then we can stave off cognitive decline. And so what it does is it's responsible. It's an antibody. So these antibodies bind to these plaques that have been formed, and these antibodies then trigger immune cells to then clear the amyloid. So this is a good cartoon picture of really kind of what the amyloid drugs do, not only aducanumab, but other amyloid drugs. And so complications of this particular drug, and if you look at the top, it now says Aduhelm. So of course, there's a brand name, a generic name for all drugs. And so aducanumab has the brand name of Aduhelm. But what we learned is, through that study, is there are what's called amyloid-related imaging abnormalities. We call it ARIA. So this drug coming into the brain, we want it to do good stuff, but as a side effect, it can also have a negative impact. And what scientists found out was that 35% of the people taking this drug on a particular dose had a 35% increase in getting swelling in the brain, and 28% getting microhemorrhages in the brain. Now, it sounds awful. However, all serious therapies, and especially life-saving therapies, do run these type of risks. So I do tell people that. And so this was just really too high for regular, neurologists and even the FDA to say, hey, this is a big side effect profile. In fact, I can say in my work, since this drug has been on the market, I've only prescribed it to 1 patient. And I made sure it was someone who was healthy enough to take this drug. So there were a lot of factors that went into this that I chose to give this person that drug. Other than that, I just don't trust it yet. I want more information from this particular drug before I will be very willing. And I actually know now we have better class drugs that are coming down the pipeline. I'm willing to wait for safety reasons. So again, drug cost analysis of this drug. It was set off at $56,000 a year. That has come down due to just Biogen, wanting to have patients in there, to take the drug. They have lowered the cost. But this really puts the Centers for Medicare Services in a bind, because how are we going to pay for this? Right now they're not paying for it. In order to get this drug, we have to make sure we're treating the right person. We have to make sure there's a biomarker that justifies giving this drug. Biomarker meaning, is there pathology in the brain? We have to somehow figure that out. So that's going to take special PET scans or cerebral spinal fluid, which is very expensive to do. And so again, when you look at Medicare Part D, which is our medications, it sets aside $30 billion for D drugs every year. If 1 million people with mild cognitive impairment and early AD receive this drug, it's going to cost the Medicare system $57 billion, can't even speak today, per year. So this is really just, this is going to change our healthcare infrastructure, actually. So I want to talk a little bit about the second drug that has come out on the market. This is actually also in an accelerated fashion. The name is Leqembi, or the generic name is lecanemab. We have been studying this drug at Georgetown now for the past 4 years. Like aducanumab, it is a monoclonal antibody. So what it does, like any antibody, it makes an antibody to attack viruses or bacteria. And so that has been kind of engineered to tell the immune system to clear this amyloid protein from the brain. This particular drug was studied in over 750 individuals. These people were in ages of 55 to 85, and we only studied people who had mild cognitive impairment and the very early stages of Alzheimer's disease. It was delivered intravenously, so someone had to get an IV infusion every 2 weeks. That's a lot for somebody. When you think about having a drug and possibly taking a drug for the rest of your life, that's twice a month you'd have to go into an infusion center or possibly a doctor's office to get this drug. It's not something you can just take at home. And again, this has been approved in an accelerated fashion. So right now, Medicare and private insurance companies are not reimbursing. They're wanting it to go through the traditional route. And it is going through the traditional route right now. And we think in July, the FDA will fully approve lecanemab. If that is the case, and I'm hoping so, again, it's really going to change the healthcare infrastructure, because now insurance companies are going to need, and Medicare are going to need to reimburse for MRI scans to look for these structural abnormalities called ARIA. We need to make sure people have biomarkers that do tell us someone has Alzheimer's disease, because again, right person, right drug, we want to make sure that's going on. And so there's a lot to think about with this drug. We need guidelines. They're starting to come out. New England Journal of Medicine came out with some guidelines not too long ago for us as neurologists to say, okay, if we were to prescribe this, what are the guidelines? What are the stipulations? Who's the right population? What should we be looking out for? So that's really still ongoing and could take another 4 or 5 months before things really get rolling with this particular drug. But I'm excited about it. I'm putting up graphs that you may not understand, but what I'd like to show you is, the amyloid burden is the plaques in the brain. So the scientists looked at the plaques in the brain before the drug was given, and then 18 months later. This particular trial lasted 18 months. And the placebo group, the group that were not on the medication, if you look here, the blue line going towards the right, this is the accumulation of the amyloid plaques in the brain. People who were given lecanemab in the trial over 18 months lowered their plaque. So when you look at this difference, we can absolutely tell there is statistical evidence saying that it did its job. It lowered the plaques in the brain for the people who actually took the drug. If we look to the right here, the two lines, the yellow and the blue, this represents a cognitive test that we had given people. And it looks at a test over an 18-month time. And what I like to point out is that even people on the drug declined. They didn't stay parallel and go straight linear. They did decline. So I can tell people, you will decline on this medicine. It's not as if we're going to halt everything and you're going to be exactly where you are now, 5 years from now. It doesn't work that way. But what we did learn was that the people who took the drug had a 27% less decline in their cognition compared to the people with placebo. So that's really what I tell some of my clients is, you'll get a 27% benefit. It doesn't mean improvement. It doesn't mean you're going to improve from where you are. But compared to not taking the drug, you may have a 27% less decline. So I guess what I think as a researcher is, what does this mean in time? If there's a 27% decrease, how much time does that give me if I'm a patient? So what we really came out with was there's a 6-month improvement after 18 months, 6 months. So my question is, if this were to continue in a linear pathway, after 3 years of taking the medicine, does that mean I have a year of improvement? after getting it for 4 years, do I get more improvement? So that's what we just don't know yet. We just don't have enough evidence. After the study, there was also a 38% decline in caregiver burden, which was wonderful to see. For this particular drug, there was a 12.6% of the study drug population did develop this amyloid-related imaging abnormality that we call ARIA edema, which is actually less than the aducanumab, which already is more promising. 8.9% of the study drug population developed the ARIA-H, which are these little small microhemorrhages in the brain. Again, that is much better than the aducanumab. So this already tells me that I'm probably never going to prescribe aducanumab because of the safety profile, because there are better medications that are coming down the pipeline for sure. And of that 12.6 and 8.9%, 78% of those subjects didn't even have any symptoms. They didn't even know these abnormalities were going on in the brain, because as researchers, we're on top of it. We are doing MRIs of the brain about every 3 to 4 months while someone's in a trial, specifically looking for these abnormalities. We're wanting to, keep our research subjects as safe as possible on these drugs. And so we're always doing brain imaging to look out for these abnormalities. And we also learned that these abnormalities occurred more often and that genotype APOE4 carriers. So that's something else to consider when prescribing this medicine. Should we also be doing genotyping on our patients to see if they are at greater risk? So breaking news, I had to add this slide in today. I woke up at 6 a.m. to a text alert from Lilly pharmaceutical company telling me that one of their new drugs looked very promising in their preliminary data. Of course, I knew I was giving this talk today, so I was like, goodness gracious. So I had to get as much information as possible before I shared this with you. This drug is called donanemab. As you can tell by the previous slides, all of these drugs I've talked about end in mab, because they are all monoclonal antibodies. So donanemab is potentially the third medication that may slow down cognitive decline in people with mild cognitive impairment and early stage Alzheimer's disease. We are currently studying the drug here at Georgetown. It is not open to enrollment. Enrollment has closed. It closed last year. But at Georgetown, we right now have about 8 patients in the trial, and they are continuing in the trial until the sponsor deems it unnecessary to be in the trial anymore. But again, they did learn that donanemab significantly slowed cognitive and functional decline in their subjects taking the study drug compared to placebo. This was given in over 1,000 people, ages 55 to 85. In order to be in this trial, we did have to make sure our subjects had a positive pathological biomarker. Again, we want to make sure we're treating the right person with the right drug. So we were able to get these special amyloid PET scans to determine eligibility through research reimbursement. So preliminary data, of course, this came from Lilly this morning, and that's why I wrote it down here. 47% on donanemab showed no decline in a cognitive measure. So a cognitive measure, we call it a clinical dementia rating scale, or a CDR. This is an interview that we give with the subject and their study partner. And we give them a score. And according to this, 47% have not changed in score since the 18-month trial period. 40% of the subjects on donanemab had a less decline in their abilities to perform their activities of daily living. That stands for ADLs, which is really important to me because, yes, I might have some memory lapses, but I still want to do what I want to do. I still want to be able to plan a meal. I still want to be able to do laundry. I still want to be able to do my everyday activities. That's what's important to me. So to have 40% less decline, in that particular area, I think is more significant actually than the previous drug I talked about, lecanemab. And then this is astounding, but 71% of the people on donanemab achieved these this clearance of this protein in just 12 months. So I'm cautiously optimistic. I don't have that much information. All I have is what Lilly has told me. But again, this is preliminary data. So what that means is they've taken half of the population, or maybe more than half the population, and have collected data. They have not collected the entire 1,100 and so subjects and looked at all of the data, because not everyone has completed the trial. Everyone comes into a trial at different stages. So I'm cautiously optimistic, but this is great news, and it may be on the news. I'm driving to work, and I was listening to WTOP, and they actually mentioned it on the news at 7 a.m. And I was like, oh my gosh, I can't believe this is already out so early. So when it talks about the side effect, again, all of these anti-amyloid therapies have this side effect of this amyloid-related imaging abnormality, this ARIA. For the people who had the swelling or the edema, that occurred in 24% of the study drug participants, and 31.4% it occurred with people who had microhemorrhages. So that percentage in side effect is actually a little bit more than the lecanemab. But again, this is preliminary data. This isn't the whole picture, but it's still very exciting. So right now we have 2 drugs that are on the market, one that's accelerated that hasn't been fully approved, lecanemab, and now a 3rd drug, donanemab, that is looking like it's going its way towards the FDA. So really quickly, I don't have much time. So I know that we're looking at amyloid plaques and these tau tangles, but these circles really represent what other scientists are doing. We're not just going down one path. We're looking at neuroinflammation as a research method. We are looking at stem cell research as a research method. We're looking at insulin and glucose and how that plays a role in Alzheimer's disease. And so we're focused on that. Vascular risk factors. So we're looking at it really outside the box. So I just kind of this is just really to tell you that there's so many other avenues of research. We're not only focused on these plaques and tangles, but researchers are really thinking outside the box and looking at it in many different other ways. So there are many drug trials going on in phase 2 and phase 3 right now. So what does the future of Alzheimer's disease research really look like? And what it really comes down to is much earlier detection. We have discovered biomarkers, these biomarkers meaning these amyloid plaques and these tau tangles, but I'm sure there's other biomarkers out there that we just haven't yet discovered that is equally important. And so technology will help us, push through that. And then better brain imaging. I mentioned that in research now, we have these amyloid PET scans where we can really see these plaques in action, where we can't see this on an MRI or the glucose PET scan. But we are now coming out with tau PET scans. So this is specific to the tangles, for example. To the right there, I put a blood test. So this is also very exciting news. I really do think in the next 5 years, you can go to your doctor, get a blood test, and wham, you'll find out if you've got a positive biomarker. I really think that's going to happen. And it's so much less invasive and less costly. So there are companies out there. Precivityy is a company doing a blood test. It's not FDA approved. Quest is now doing a blood test, and it is not FDA approved. So it really hasn't, because of that not being FDA approved, it's not really known in the community. Not a lot of local neurologists know that there's even a blood test, because we just need to know a little bit more about it. We need to have more, we need to know more about its specificity and sensitivity. How accurate is this blood test? Am I going to get a false positive or a false negative and give my patient misinformation? So it's out there, but we need to learn a little bit more about a blood test. But I do believe in the next 5 years, maybe even 8 years, it's going to be something standard that we do. Better treatments, again, disease-modifying drugs. These 3 are doing that, and they're targeting the hallmarks of Alzheimer's disease. And what I think is going to happen is it's going to be a combination of these modifying drugs, similar to a cocktail of getting 2 blood pressure medications in one pill to tackle your hypertension. I can only see that these drugs are good, but how good would they be if we actually put them together? So I think that's something that may be coming down the pipe in a couple of years too. And again, prevention. So we're out there really doing talks to people who don't have any symptoms at all, and really teaching them how to stave off cognitive decline. And this should be taught, as early as childhood. I'm trying to teach my 23-year-old daughter physical exercise, Mediterranean diet, be a lifelong learner. It's Alzheimer's disease is not a single disease. It's not like COVID where we can pinpoint a virus and say, okay, hit that, tackle that, erase it. There's just so much that's intriguing about Alzheimer's disease. It can be genetics. It can be our lifestyle. It can be our environment. It can be happenstance. We just happen to get it. So it's not just one entity. But research, has demonstrated that lifestyle changes actually do influence the delay of Alzheimer's disease. It may not prevent it, but if I know what I'm doing now, let's say I'm going to get it anyway, I'm going to get it. I'm just going to. But if I'm doing what I'm doing now with my health, am I delaying it by 5 or 10 years? So instead of getting it at 75, maybe I'll get it at 85. I'll take that risk. I'll take that extra 10 years of having some functional, independence. So it's never I tell my patients, even in the early stages, it's never too late, to begin a change in your lifestyle. You will stave off cognitive decline, even in the early stages of disease. So getting involved in research. So at Georgetown, we do different types of trials. We really do phase 2 and phase 3 trials. We do longitudinal trials, meaning that we're just observing the subject. We're not interjecting investigational medication. We're just observing them over time. We look at repurposed drugs. So for instance, at Georgetown, we are looking at the nicotine patch and comparing it to placebo to see if it can stave off cognitive decline. It sounds weird, but we do have a transmitter in our brain called nicotinic acid. And it actually enhances with the substance nicotine. And so we're studying that. And we're also looking at metformin, which is a non-insulin dependent diabetic medication, to see if, again, there's this dysregulation of sugar and insulin in the brain. If we can better balance that, are we staving off cognitive decline? So those are 2 of our repurposed drug trials that we're doing at Georgetown. And again, we're also doing investigational studies that really are advancing our understanding of how to potentially prevent the onset of Alzheimer's disease. So what this is really called is prevention studies. So that little chemistry cycle wheel that I showed you earlier, where this was occurring 10 or 15 years before, well, let's start getting people who are cognitively healthy in trials who may be at risk for getting Alzheimer's disease, that are starting to develop these plaques in their brain. Let's get them now at this stage to see if we can just prevent the onset of Alzheimer's disease altogether. So we do have one prevention trial going on right now for healthy individuals without Alzheimer's disease, but maybe they have a risk factor. Maybe their mom has it. Maybe they know their APOE status and they have a risk factor. So we are looking for people starting at the age of 65 in prevention trials. And then there's also blood-brain biomarker banks that we're just collecting people's blood and just studying their blood. And then there's brain registries, which I will get to in the next slide, where I've even signed up for. You can sign up for these websites and these registries where they'll take your demographics and your information, and you can do brain games, and they can possibly even test your APOE status to see if you have a risk factor for Alzheimer's disease. And the whole point of registries is really to advance the knowledge and the research of brain health. If someone were to get into, or one of my viewers here were considering research for themselves or a loved one, first thing we would want to do is my information is at the end of the trial. The whole process can take about 4 to 6, maybe 8 weeks. I typically talk to the person on the phone first, get some information. Why do they want to be in a trial? What are the pros and cons of being in a trial? Generically, I'll talk about that. And if this is a serious decision that someone wants to make, then I will gather their medical records. Or again, I want to make sure someone's healthy. I want to make sure that the diagnosis, is what it is. We have to make sure we're putting people into the right trials. If I review the medical records, I then make a call back to that person, review the medical records, and then send them a consent for a particular trial that they're interested in, have them look over that consent. We talk again about the consent. Are there any pages you didn't understand? What are the side effects of the trial? What are the pros? What are the cons of this particular trial? Is it right for you? Because each trial is different for each person. And then if it still is positive, and I believe they would qualify for the trial, then we would schedule a screening date. They would come into Georgetown Hospital, which is off of Reservoir Road. Our research trial is on the first, I'm sorry, our research unit is on the first floor of Georgetown. And we would do a screening visit, which would take about 3 or 4 hours. All of our trials involve a study partner. So this is a reliable person who knows the subject well. At least spending 10, 15, 20 hours with this person, because they will periodically get interviews where we're asking them questions about how well they do on a day-to-day basis. So someone would have to have a reliable study partner to come in with them for their study visits. And so the screening phase, once someone does screen and sign the consent and we start the ball rolling, the whole screening phase then may take a couple of weeks as well, because it would also mean extra MRIs of the brain, special PET scans to determine whether or not someone does have these amyloid or the plaque and tau tangles in the brain. All of our research trials are actually reimbursed through the sponsor. And the sponsor is either a pharmaceutical company, it could be the Alzheimer's Association, it could be the National Institute on Aging. And so anything that is directly related to the trial, any tests, any imaging, any blood work, any evaluations are reimbursed. So I tell my subjects who come into trials that you don't need your Medicare card. I don't need to see your insurance. This is absolutely going to be reimbursed by the trial sponsor as well. So this is an important slide here, and I'm sure that Kirsten can share this with others who maybe want copies of the slides, but websites for guidance. So our trials at Georgetown are on our website, memory.georgetown.edu. You will find our trials there. If you see a trial and you just want to know a little bit more about the trial, you can go to a national registry, clinicaltrials.gov. Every trial has to be listed there. So that's another source to go to. And again, there are some registries below there that you can sign up for. It provides you with brain health information, maybe resources to help reduce your risk of brain disease, and to advance, of course, your knowledge and research on brain health. So there's a couple of brain registries there, Gene Match and APT Web Study, that you can also go to as well. And that is the end. Thank you for attending. My email address is in red there below this gentleman having fun at the beach, staying physically and mentally and socially active. And then below that is my business work phone. So I'm sorry if I talked a little bit fast towards the end. I'm keep looking at the clock and know that I only have about 15 minutes. And I haven't even looked to see about questions because I still have it on screen share mode. So I haven't looked at the chat. So I'll let
Melanie,
you
you were
Thank
great.
you so much.
No, do not apologize for rushing. And I think all of us were too glued to what you were sharing to even dare try to type something in the chat. So we actually do not have any questions typed in yet, but I think we should give it just a minute or two. And I just want to thank you for what you shared, because they're, like you said, fresh off the press this morning, but then even just dipping into other things like the prevention aspect. And so I do want to make the offer. I hosted an event in January featuring the Mind Diet. So a dietitian came in and spoke about that. So it's a combination of a Mediterranean style eating pattern as well as a kind of a hypertension diet. So looking at low blood pressure and having low sodium. So I have a couple of those books still from that event. So please, to anybody attending on today's call, if what Melanie said about the Mediterranean style eating pattern, if you're like, I don't know what that is, or I'm not, familiar with that, go ahead and email me, and then I will mail you a copy of this book that I have from.
Did you email me a copy too?
I'll mail it to you. Yes.
Oh, good. Yeah, that would be very, so if I needed copies to give out to some of my participants. I mean,
I have a handful. I have a handful,
I was
Melanie.
like,
So
if there's a way I can get some books myself, not just, mooching off of you.
absolutely.
Yeah, that
So
would,
we do have one question. For meds now approved by FDA, what is the risk of adverse side effects such as dizziness that increase the risk of falls?
let me look at that. For meds now approved. So it's not a confusing question, but the medications that are currently approved by the FDA prior to 2021, those are the drugs like donepezil, rivastigmine, memantine. Those drugs do carry a side effect profile because what happens is, which I mentioned earlier, if we're enhancing a neurotransmitter in the brain, unfortunately, as a side effect, we also enhance a transmitter in the gut. And so what can occur in at least 5% of people taking these older drugs is some GI or gastrointestinal complications sometimes. So that could be in the form of nausea, lack of appetite, loose stools or diarrhea, maybe even a little weight loss. And dizziness can be one of those side effects, and that can happen in about 5% of the people taking the drug. Again, the person prescribing really has to understand this person's medical history and what could potentially increase their risk for these side effects based on previous, medical history that they already have. But it definitely can. I can't believe I didn't get any more questions. Usually I have more questions than time to talk.
I'm going to make the guess that we are all a little bit overwhelmed. It's a lot of information.
It was, I know.
And that was kind of you to share your email address. I will be sharing the slides with everybody who attended. And so your email address is printed on that last slide. So I know that's probably going to be a question. How do I follow up with Melanie? So
Yeah.
We'll get your contact information out. Today's event has been recorded, so that link will also go out. So Melanie, thank you so much. You did talk a little fast. I'm guilty of that. So
it's hard. It's hard in an hour and a half when there's so much.
Shared so much with
and
us.
I think that the takeaway of the presentation is there is hope out there. We have come a long way. Yes, there has been failures, but we had to have the failures to understand how to have the success.